when I say that Lewy body disease is the most complex of the dementias, I don't want to trivialize or belittle folks who are living with Alzheimer's, frontotemporal dementia, or vascular dementia, because in individuals, they too can have very atypical or complex presentations. And many of those folks end up in my clinic for exactly that reason. But if we take all comers and we are talking in textbook generalities rather than particular lived person experience, Lewy body disease really does have more, and I love Pat's phrase about this, more moving parts. And in fact, I am going to formulate my conversation for the next 10 minutes or so around Pat's model of the 5 moving parts, adding something that is implicit in her model, but I'm going to make explicit, as if you will, the 6th feature, which is her term, her phrase, moving parts. So in a disease like Alzheimer's, there is a gradual trend toward progressive worsening, but any given day is very much like the day before and the day after, barring external events. In Lewy body disease, there is this very unusual fluctuation in each of the different components of the disease that lends itself to Pat's term moving parts, because there really can be a very dramatic difference from one day to the next, and in later stages of the disease, in 1 hour to the next, in terms of that person's symptoms. So alone of all the dementias, I can literally have a patient go from wide awake to falling asleep in the same 10-minute epic of their interview with me in the office. And every one of the features of Lewy body disease can fluctuate in the same way that alertness does. So to some extent, motor symptoms can switch on and off. Sleep cycle disturbances come and go. Autonomic features, although they are, as a rule, more steadily present from week to week, can also change over a relatively short period of time, let's say a few weeks. And certainly every single one of you who's a caregiver to someone with DLB knows that the anxiety or the hallucinations can be there very severely 1 minute, and a few hours later just seem to be evaporated, based on time of day. So I'm going to talk briefly about some of the less common features of each of the 5 pieces that Pat outlines in her eloquent talk. The first one being the autonomic system. So many of you may have experienced feelings of lightheadedness or dizziness transiently when standing up for 30 seconds or so. And may even know that the autonomic system is responsible for regulating your blood pressure when you go from lying to sitting or sitting to standing. What you may or may not have experienced in caring for someone with DLB is that they will have very substantial dysautonomia that creates more persistent blood pressure problems when they stand up. And those can show up even several minutes after getting up to stand and walk around, so that suddenly people with Lewy body disease will fall to the ground. This sometimes has warning in front of it, and sometimes really just creates what looks like a near faint episode where people just kind of collapse. That tends to happen later on in the disease, not right in the beginning. But that is, we think, part of this dysautonomia, especially to do with blood pressure. Some other autonomic symptoms that you may or may not recognize as being part of DLB are excessive liquid formation. So drooling, nasal drip, excessive tearing, okay, those are all a feature, as is impotence, which is obviously much more pronounced and noticeable in men, although the equivalent of impotence, which is problems with clitoral arousal, happens in women too. And forgive me for bringing it up in, forums such as this, but I really do think that it's important to talk about sex. It's an important part of our lives, and as human beings, we all engage in it, and it can be very traumatic to kind of be going along and not have anyone to discuss that with. And there are some measures that can help. If that is a part of your loved one's presentation, please go ahead and ask me. The second piece, behavior. Not only are hallucinations an issue, which you probably are well familiar with, I'd like to point out that apathy is not the same thing as depression, and apathy can be a very strong symptom in Lewy body disease, in fact, in many of the dementias from time to time, and needs to be treated as its own separate issue, separated out from depression, which has, for better or worse, better medications to treat it. And I already alluded to the very severe anxiety that some people with Lewy body disease experience. If I talk about cognition for a moment, which is Pat's third moving part, there is a pattern of cognitive change that characterizes typical Lewy body disease, okay? And it is pretty different from what you see in Alzheimer's. You see, first and foremost, a growing, slowed speed of processing, okay? And it shares this in common with Parkinson's disease patients. And this reflects the subcortical component of Lewy body disease, which affects the basal ganglia, so deep gray nuclei in the brain, that helps to control timing of both physical motor movements and also cognitive ones. So people get slower on the uptake. It takes them an extra second or two to put information together, and it's why it's so important when you're caring for somebody with DLB to slow down your conversation and give shorter pieces of data at a time, not like longer strings the way I'm doing right now. That slowed speed of processing sort of facilitates and makes worse another problem, which is executive processing deficits. So we think of the front part of the brain as having this ability to integrate and tie together the various elements of thinking so that you're able to sort of consciously direct your attention and control what it is that you're paying attention to, what it is you're kind of selectively tuning out in the background, and most importantly, being able to switch your attention back and forth between competing tasks that you need to be doing simultaneously, or at least in parallel. So that type of executive processing is unfortunately very much impaired in Lewy body patients. The third element of the cognitive impairments is visual spatial skills, much more strongly than in many people with Alzheimer's. At an early stage, there is a very severe visual spatial integration deficit. That means that people with Lewy body disease often have trouble finding things that are kind of in their direct vision, if they would just kind of notice it or put it together across a head turn this way versus a head turn that way. Oh, okay, those are both halves of the toaster oven, for example. You may have noticed, right, somebody looking right at the microwave door and wondering how to open it. And it's because they're kind of looking in one spot and not seeing that other spot on the same larger appliance. I'm happy to answer more questions as we go along about what to do about that, or at least how to help. The fourth component is Pat's motors, is the motor system. We talk a lot about how Lewy body disease is kind of this marriage, poor marriage, between Alzheimer's disease and Parkinson's disease. So you see a lot of the components that people with Parkinson's get in Lewy body. I will try to point out that both in Parkinson's and in Lewy body, the motor deficit is not one of weakness. It's not one of cerebellar incoordination. What it is a deficit in motor planning and motor execution, okay? And that means not just impairment of walking and balance, which requires motor planning. There's impairment in speech, okay? You'll notice soft, whispery speech in some people with Lewy body disease, and difficulty in articulating individual syllables as they go along. So that's the same motor planning problem, as is sometimes deficits in handwriting. So lots of pieces, components to that motor deficit that you wouldn't necessarily think about immediately if you're thinking motor system involves just like lifting and carrying. I will say that in all of my patients with both PD and DLB, I highly encourage pursuit of skilled motor planning exercises. So that is a short list: dancing, yoga, and martial arts like Tai Chi. The last component that I'll talk about that's on Pat's 5 moving parts is sleep disruptions. And these run the gamut. It's really you almost need to think about the problem as being a circadian cycle dysregulation, okay? So in our brainstem, we have various elements, neuronal and chemical, that regulate when you go to sleep, when you wake up, and not just when, but how you fall asleep, okay? When you fall asleep, normally, you sort of drift off and you go through a few phases in the brain that happen kind of seamlessly, one after the other, in an integrated format until you're in deep sleep and then dream sleep. So not only is sleep dysregulated in the sense that Lewy body patients have excessive sleepiness in the daytime and simultaneously may not be able to stay fully asleep through the night, so they have a lot of fragmentation. But in addition, those individual components of falling asleep become dysregulated, so that they might start out very early on in dream sleep, which that is supposed to happen much later in your cycle. And at that time, they're not paralyzed the way we should be when we're dreaming. So they act out their dreams instead of holding still. That thing is called REM sleep behavior disorder. There are other problems too. You might actually be paralyzed for a short period of time as you're falling asleep or as you wake up and not be able to move, but still be kind of sort of awake, which is a terribly unpleasant feeling, and which sometimes makes the process of falling asleep very unpleasant for Lewy body patients, especially if it happens frequently. They may also have elements or fragments of their dreams that persist into waking, so that in addition to other forms of hallucination, people with DLB will see frightening or maybe pleasant, but definitely dream images when they're fully awake. So all of this sort of circadian cycle disruption is fascinating for neurologists and sleep scientists to study, because it teaches us a ton about how and why the human body actually does all of this, but man, it can be challenging if you're the one living with it. Just shows you how important that 8 hours we spend in oblivion every day is. Okay. So I look forward to answering questions about any or all of these 5/6 components of Lewy body disease. And with that, I will turn it over to Pat or Lynn or whoever's going to moderate and take questions.
Okay, there we go. Okay, I needed to unmute myself. All right, everybody. Now we can't see your hands. And so for all of you that may have a question, so what you might do is, if we cannot see you, if you would put your question onto the chat, what I will do is check the chat and know that you are trying to put you in line, so to speak. For those of you who are able to, we can see you. If you'll just raise your hand, we'll try to unmute you. We're going to start our Q&A, and we've got an eager person who's already got a question here. Mike Hardison is, what is the best way to treat anxiety with DLB? Our mom experiences high levels during the afternoon and early evening.
First line is always going to be an SSRI, okay? And that may be a little bit counterintuitive because if you've heard of SSRIs, then the context in which you've heard about them is that they're antidepressants. That is true, they are. However, some of those SSRIs are actually pretty darn good at calming anxious episodes. Now, that doesn't mean that it always works or that it works perfectly. Somebody's anxiety may be so severe that despite maximum therapeutic SSRI use, they remain somewhat anxious. And a second element of what I use is behavior modification, not of the patient, but of you, the caregiver, and of the environment. Okay, so in addition to medication, very often people have particular triggers, things that you may or may not recognize or notice until you start looking, but which act as sort of the nidus of their anxiety. And a major part of how to treat it is to help resolve those aspects. So if somebody gets anxious because they're in a particular room or they're anticipating a particular activity that's going to happen, then I brainstorm and strategize around how to make that in place, space, or activity less stress inducing, and try to bring that together with the pharmacotherapy. I guess I should ask Mike, if is your mom already on maximum SSRI? Do you know?
This was done in the chat. Let's see, Ativan.
Oh, okay. I didn't talk about what you shouldn't use. Okay. Yes. I spoke about what you should use. All right. A big no-no with all of the dementias. God knows this is not specific to Lewy body disease. Big part of what I do in my job is take people off of offending medications. And the number one most egregious offender is what are known as the benzodiazepines. And while the benzodiazepines are a problem in every single dementia, and I'm always trying to get rid of them, they are exceptionally bad in Lewy body patients who tend to be very sensitive to medication in general, and to psychotropic medications in general. In fact, that extreme sensitivity to certain classes of meds is one of the hallmarks that we use to diagnose people as having Lewy body disease. So benzodiazepines are what are known as minor tranquilizers by pharmacotherapeutic experts. And the problem with them is that they wear off. Okay, so especially a drug like Ativan, but even the longer acting ones, they fluctuate. And that puts them on that fluctuation on top of the Lewy body patient's innate intrinsic fluctuations, so that it magnifies, it amplifies their pre-existing tendency to have parts of their cycle, their 24-hour cycle, in which their mood is worse each time it wears off. So Mike, talk to your mom's doctor about weaning her slowly from her Ativan while simultaneously putting her on an SSRI. And sertraline is my go-to. It has very good anti-anxiety properties. It's dirt cheap because it's been around forever. And you can play around with the dosage very easily, you know, so you can use tiny amounts and then build it very gradually, which is what most people with Lewy body need.
Wonderful. Okay, Hannah Bowen has a question. It's 3 questions actually, but they're all wrapped around the COVID issue. So she would like for you to speak to the impact of COVID on Lewy body dementia. Is the vaccine recommended? Once they're vaccinated, are there other precautions that should be recommended for these patients? And is there an increased chance that a COVID infection will set back the patient with Lewy body dementia?
Sure. For God's sakes, get the vaccine. Full stop. End of story. I cannot think of any legitimate justification for not getting vaccinated when you can. There is no disease that you could possibly have that would interact so negatively with vaccination that you would prefer to get the disease than get the whatever it is from the vaccine. Okay. And since most Lewy body patients, at least the ones that I know of, are over 50, at this point, every Lewy body patient should be, if not already vaccinated, at least in line to get their vaccine. Please do it. Is there an increased chance that a COVID infection will set the patient back? Of course there is, because any illness, even a cold, even just staying up late the day before, even a minor stomach upset can cause temporary worsening in people with dementia. And anything that does this temporary worsening can do it even more so in a patient with Lewy body disease who is prone to these worsenings for absolutely no good reason other than that it's Thursday. Yeah, COVID infection is problematic. I won't belabor this anymore. Please get vaccinated. Okay. So I have. Oh, I'm sorry.
I'm sorry. She wanted to know: are there other precautions that, in other words, once they get it, are there special things you need to do because Lewy body is in the story? Any impacts and things, and is there anything you can do to make it easier?
Once a patient is vaccinated, their risks go down to that of a human out there in the world who has Lewy body disease. They're not more susceptible to getting COVID once they're vaccinated than anybody else. No, there's nothing about Lewy body disease or any of the other dementias that will make a vaccinated person more susceptible. Please remember that older people's immunity is not quite as good as a younger person's immunity. Older people in general tend to be the ones who get the flu after they got their flu shot. So if you're over 75, I would encourage you to keep kind of reasonable precautions about getting infections, not just COVID, right? But all the other things that are infections that we can get by being out in the world. But that doesn't mean you should stay home. One of the worst things about this whole pandemic has been the terribly negative, very harmful impacts on people living alone, who are now, you know, a year plus into with having no human companionship. That's horrible to the human psyche. So go out intelligently. They are telling us to continue wearing a mask, right, when you're out in public, but you can get out and be with people. All right.
Okay. You are, yeah. Okay. And one of the things I was going to recommend for many of you are in the Wake Forest, Raleigh area. Some of the parks around where we live are just wonderful, sunny, breezy, delightful places to go out and just sit at a picnic table or take a brief walk if they can still move, or if they're in a wheelchair. Get out there and you just see other people and dogs running and children playing. That in and of itself is just going to lift the spirit. And if you wear your mask and you stay far away from everybody, you're going to be taken care of. Next question. You ready, Dr. Bozoki?
I am ready, yeah.
Okay. How are the motor deficits treated if not using the Parkinson's med Sinemet? How does Namenda work hand in hand with, these are, okay, that's the second question. So I'll come back. This is Terry Browning's. Her first one is, how are the motor deficits treated if not using Sinemet?
Sure. So I want to distinguish between somebody who is DOPA responsive and somebody who is not DOPA responsive. So unfortunately, for better or worse, while Parkinson's disease is almost defined as that form of Parkinsonism that is responsive to L-DOPA, only about a third of patients with Lewy body disease have that form of Parkinsonism, okay? So that is, if you give them any amount of L-DOPA, their motor symptoms will not improve, presumably because they're lacking not just the dopamine input, which is what's wrong in Parkinson's disease, but they're lacking the receptors on the far end in the basal ganglia that are where the dopamine attaches. Okay, the reason I'm telling you this is that I can flood a person who's not DOPA responsive with all the Sinemet in the world. It'll just make them throw up and, you know, make their blood pressure drop, but it won't make their motor symptoms any better. So if your family member is not on Sinemet because there was a previous trial of Sinemet and it didn't help, then none of the other medicines for Parkinson's disease are going to make a damn bit of difference, because all of them are designed to increase the amount of dopamine in the brain by directly stimulating the brain to make it, like that's pramipexole and selegiline, for example, those drugs, or by providing its precursor so that it gets through the blood-brain barrier and it can be turned into dopamine, and that's Sinemet. So I, without knowing the specifics of your family member, if they've not been exposed to Sinemet, that's the one to start with, okay? And if they can't tolerate it, that is, it makes them puke or something else too much, then they can be tried with one of the direct dopamine agonists, okay? But if the reason they're not on Sinemet is because they didn't respond, then there aren't others to try.
May I ask, may I add something to that question or ask an additional question about it?
Yeah.
What about something like the antispasmodics? I know my husband would have these spasms in his muscles. Is that also true? If you didn't respond to Sinemet, they won't work, or are there other options and for things like that?
Right, sorry. So when we talk about motor deficits, that term is largely used in neurology world to describe the Parkinsonism that is part of Lewy body disease. The rigidity, sometimes tremor, sometimes not, the slowed movements, the soft speech, the poor handwriting, these kinds of things. Those are problems that can sometimes respond to dopamine, but don't always, okay? Now, there are other types of motor complications, Pat. Some people do get these cramps, these muscle cramps that you're talking about. They're not thought about as being a Parkinsonism problem. They're thought about as yet another, and I would probably lump that one under autonomic symptoms more than motor per se. And yes, there are definitely things that you can do to help some of the other physical, I guess that's a better term, physical problems that DLB causes that are not Parkinsonism.
Right. I think we lay people, if it involves a muscle, we think Parkinsonism. And so that's very helpful to know it's a different category of treatment.
Yeah. So just as an example, a lot of people who are on Aricept or one of the two other cholinesterase inhibitors will get more muscle cramps. And why is that? And it's because acetylcholine is not just in the brain. Acetylcholine is actually at the junction between the nerve and the muscle all over your body. And when you have more acetylcholine floating around in your body, you have more tendency toward muscle cramps. So it's an issue at times for people who are taking, Aricept. Okay. There was another question, I think, related.
Yes. Terry's second question: how does namenda work hand in hand with Exelon to assist with the memory? Is her question.
We're not real sure. I can tell you this much. Namenda or memantine is an NMDA antagonist. The Nmda receptor is yet another one of those things on the surface of neurons. And it happens to be a receptor that is tied closely to integrating information that comes into that cell from multiple locations. So it acts kind of like, well, I could say an AND gate in programming, but that may not help explain here. It means that you have to have both this signal and this signal to make the cell go, all right, to fire and be used. So NMDA receptor antagonists like namenda help cells to function in a more integrated manner. That's the best I can do. And honestly, namenda doesn't just help with memory. It actually helps more generally with other aspects of thinking and behavior as well when it works. So it's much less specific than the cholinesterase inhibitors like Exelon.
Okay, I need to make sure I'm telling people the right thing all over the country. What I say is that namenda or memantine is addressing more, oh shucks, it just left me as soon as I said it. The cholinesterase inhibitors are addressing acetylcholine. Namenda is addressing glutamate. Those are two different neurotransmitters. And I describe that as two armies fighting the enemy in the middle from different directions. Am I saying the right thing?
You are. That's absolutely right.
Okay.
And right. So its benefits to memory augment the ones that, that it's a second thing that helps memory function on top of the more specific memory improvement caused by Aricept and Exelon and Razidine. Yeah.
Okay, that's a relief. I don't want to tell people the wrong thing. Okay, another question from Sonia. Did I miss an alternative to the non-DOPA responsive individuals? Is there an alternative?
No and yes. Okay, so first of all, I don't say that somebody is non-DOPA responsive until I have gone up to 2 tablets 3 times a day of regular Sinemet. Okay, so that's kind of definitely, if you've only gotten 1 or 2 pills a day and it didn't do much, so you stopped, that wasn't an adequate trial. Okay. Having said that, 2/3 of patients with Lewy body disease are not really DOPA responsive. So at that point, I still can use medications to help with particular specific problems, though in my experience, physical therapy and occupational therapy have proven more valuable tools for getting around some of those things than drugs. So in other words, if you have a person who's really plagued by soft speech, hard to understand speech, the Big and Loud program works better than a medication. In many cases, it works better than Sinemet for improving speech. A variation of Big and Loud focused on physical motor writing will also help them to improve their handwriting, because it's the same problem as in speech. Your handwriting gets real small, and you need to make your movements bigger to get that to work right. So Sonia, not really. But there are a few tricks of some medications for some motor problems that aren't Sinemet.
And if I can add to that, I had to do this with John. And what you look for, Sonia, is a speech therapist or a physical therapist. And when you're Googling and looking for these people in your community, look for Big and Loud. And there was another name, I can't remember. There was another specific name that speech therapist was trained in that was specific to helping with that volume as well as cognitive expression. And she worked magic with us, and it was wonderful. It doesn't last forever, but it does help. Okay, I think Sylvia, did you get your question answered about the leg cramps at night?
What leg cramps at night?
Okay, she said, can constantly having leg cramps at night be part of this Parkinson-like issues? I think she's dealing with what we were talking about before.
Yes. Lots of people without DLB get leg cramps at night. So it's definitely not a thing that is specific to DLB. Having said that, people with Lewy body are more prone to getting leg cramps than other folks. And if your person is on a cholinesterase inhibitor, that is going to facilitate or worsen their natural tendency to get them. So my first line of attack, so to speak, is magnesium oxide. Okay, hopefully they're already on it. If not, that's definitely step 1. 1 to 2 pills in the evening. Dietary change to like Google the list of top 10 foods that include potassium, that are high in potassium, because it's not a very intuitive list, and start having them eat some of those every day. It's a delightful list. For once, it's not like kale, it's dried apricots and nice things. If that is still not helping, there are muscle relaxants, including ones like Flexeril. They're not great for cognition, but if they're taken just at bedtime, or Xanaflex, it can help through the night without, and will have worn off by morning. But I don't go there until you've maxed out the more, harmless remedies. And Pat, I noticed there is a question from Julie, a little higher. And is this the preferred? I just want to step back for a moment. Is it the preferred method to put your questions in the chat, or do you, if any of you would rather like verbally ask me your questions because it's more complicated, or you want to, that's fine too. Maybe Pat, I don't know how you want to handle like somebody like raising their hand.
Yeah, I haven't seen anybody raise their hand, and they're seeming to go to the chat. So that's what I've been doing. Okay, well, Patrick, we'll get to you.
Okay, yeah. Okay, so so this question from Julie is Tramadol appropriate use for pain? I'm not a fan. I'm not a fan of anything that acts at the opiate receptor. Look, sometimes it can't be helped. And people with acute pain are different than people with chronic pain. Okay, so if you just got surgery and you're in that first few days of recovery, for God's sakes, you know, that kind of takes priority and precedence. And if the person ends up a little loopy, oh, well, they're still in the hospital, right? You know, you need to address pain so that they can be comfortable. But if you're talking about chronic pain, then non-opiate strategies are really preferred. Tramadol is, no matter what they tell you, it's a partial opiate agonist, and it will make people chronically more confused than if they're not on it. It's not that I have great alternatives. My go-to thing I like the most is acetaminophen, which you know, we all know and love to hate on, but it truly for chronic pain is probably the best, especially like arthritic pain, the best thing that you can be taking if you, because you have to take it week in, month out, right? And your body has to be able to tolerate that. Okay.
Okay, Patrick, and then we're going to go back. Well, Sylvia, I see you have another question. Patrick, can you ask your question?
Yeah, just in the last few months, it seemed to like deteriorate. Like, is this kind of like the progression of the disease, like the body deterioration? Her Suzanne's muscle weakness has gotten like really noticeable worse. Her appetite is like there's hardly any appetite, and severe fatigue. It seems like she's getting into like this. She wants, in the last month, sleeping like 14, 18 hours. And also that we went through a bout of COVID the last month. Would that add to any of these signs and symptoms, something like that?
Got it. I have, I guess, 3 questions. When you say you went through a bout of COVID, you mean she was sick with the virus? Is
Yes.
that what you mean? Got it. And these symptoms, did they appear when she was getting ill? This excessive sleeping, the increased, you know, fatigue and muscle weakness, that sort of thing?
Occasionally she would have this very long sleep, you know, that she wants to sleep more than, like we were trying to do like a 10-hour, 12-hour day for her, but it seems to be going further. But it was occasionally, but now the last month maybe was more frequent, like 2-3 times a week.
Mm-hmm. And the last question is, Patrick, do you know what stage she's at? So what, and I will say, for anybody who was here last month knows, you, the caregiver, are the best stager there is, because staging is done based on function, okay? So do you know what stage she was at before she got COVID?
I think it was moderate. I mean, you know, she's still getting around. I mean, it seems to be getting worse, but she was still getting around. But this appetite and the severe fatigue kind of increased in the last few months. And then her body is even leaning a little left, which I thought was, you know, it could be a stroke. I don't know.
It's
No.
not.
Okay.
It's not. Yeah. So your answer is in your question, kind of. So yeah, this is definitely, a lot of it has to do with her acute illness. So this goes back to what I was saying, that when people with dementia get sick, I mean, you only have to look at them funny. Like they can have a minor cold and all of a sudden they're more confused or they're more fatigued. They have so much less reserve than a healthy individual. And an illness as substantial as COVID in a person who's already moderately demented, with particularly a dementing illness that has as one of its cardinal hallmark features dysregulation of the sleep-wake cycle, that is going to be kind of a perfect storm to make her look and act and feel just much, much worse while she's recovering. And regrettably, it can take, I mean, we hear stories about those COVID long haulers. I don't have a lot of knowledge or understanding, but I know from those stories that COVID the after effects linger, regrettably, for months. So I can't promise you that, you know, she's going to be better again anytime super fast, right? But the natural history of COVID is to improve over time, and hopefully as your wife kind of climbs out of this illness setting, she will also improve, possibly not all the way back to her pre-COVID baseline, but pretty close.
Should we get the vaccine?
Yes.
Okay. Thank you.
You're welcome. Sure. Yeah.
Okay. Yes, and I do want to comment to that leaning to the left. Among LBD caregivers, that's called the Lewy lean.
Okay.
That is a classic.
Your center, the ability to know when you are upright, okay, for me to just inherently be like this and not this way. There's a complex set of information that has to be integrated in the brain. Okay, coming from the ears, the eyes, and the proprioceptors in the body, for me to be able to do that. Think about, you know, like a little baby has no idea. They sleep in the weirdest positions, and, you know, they have like no clue. So that's because that part of the brain hasn't yet learned how to integrate the information. In Lewy body disease, part of the autonomic dysregulation that happens, you lose some of that ability. Okay, thus the Lewy lean. I didn't know it was called that.
That's what caregivers call it. We have names for all kinds of things, and it's called the Lewy lean, and it is almost always to the left, which everybody's like, what?
What?
Yeah.
Okay.
But that's what happens.
I wonder if that has to do with, we should do a study and see if left-handers lean to the right. I wonder if that's a handedness thing.
I don't know. Okay, here's Sylvia is accommodating. She says this is not a personal question for her, but she does want you to have the chance to address this for everybody. Where does a caregiver go for help when the loved one is repeatedly displaying unhealthy sexual drives, in quotations, that creates extreme tense interactions?
When you say where does the caregiver go, so where you go for help is your friendly neighborhood, either neurologist or psychiatrist. We're the ones, these two groups are the ones who tend to know how to manage this sort of an issue, although I suspect that there are some pretty savvy internists out there as well, and geriatricians. And I guess the answer is a little bit complicated. It kind of depends on what exactly is happening. So there are some people who will masturbate in public or kind of take their clothes off to expose themselves in public. If that is the case, preferable to putting them on medications might be curtailing their public outings and interactions until they are past that stage. And this is truly a stage for many folks of their disease, and they, for better or worse, do, after a period of time, outgrow it in reverse. If the problem is sort of an overactive sex drive, and there really is no appropriate outlet for that sex drive, the SSRIs, and especially fluoxetine, at high doses, and this is a little problematic in Lewy body patients, right? Because high is a relative term, but in high doses, the SSRIs can act as sexual inhibitors. And so Prozac, which is fluoxetine, at 60 or 80 milligrams is a pretty potent sexual inhibitor drug. There are several other drugs that are used also by psychiatry to help curtail a very overactive sex drive. But I always prefer the environment alteration first. So somebody was hitting daily on, if I could use that term, hitting daily on their wife who was ill herself and just not in a position to be able to manage that. We had the ability to move mom in temporarily with one of the daughters and have dad get some in-home supervision on a daily basis with the son, and they hired an additional caregiver to, kind of assist when son wasn't around. And that really was a better alternative than sort of putting the guy on a Prozac overdose. All right.
Okay, we have another question. When is the best time to start namenda? I'm assuming that's in the context of that not being the first treatment. If you are adding that to a cholinesterase inhibitor, what's the best timing on that? There's conversation about this in the LBDA community.
Okay. So the problem with both cholinesterase inhibitors and namenda is that neither one of them have been formally trialed in Lewy body disease, okay? And so what we don't know is whether there are any nuanced differences between how LBD patients respond versus Alzheimer's disease, which is where these drugs were actually trialed and tested. In Alzheimer's, you're supposed to wait until the moderate stage of disease. And that's because when they tried namenda in mild patients, it really didn't provide an improvement. Understanding that the metric that they were looking at as an outcome in Alzheimer's disease was predominantly based on a test like the MMSE, the Mini Mental State Exam, which looks fundamentally at memory and orientation. So on a test of memory and orientation, Alzheimer's patients didn't get better in the mild stage. Now, I tend to be a little more lenient in my Lewy body patients and start it earlier because they have so many non-memory problems. And in my experience, and this is just an anecdotal, not data kind of statement, right? The namenda has more generalized effects, and the problems in Lewy body are more general than specifically memory. And so I seem to have better response earlier on in the disease. Long-winded statement. So I would probably start them on cholinesterase inhibitor, give that 6 months, 8 months, something like that. When they start to seem like they're getting worse again, despite the Aricept, I will add namenda.
Okay, and there was another piece to this that's really, really LBD important that I did not include in the first part of the question.
Okay.
And that piece is if, for instance, let's say if for LBDs, it's classic, there's some Parkinson's or Parkinsonian symptoms in there. So Sinemet is also introduced into the story, maybe fairly early on for some patients. And that realize maybe that's not working. So the doctor is going to withdraw that Sinemet from the story, and you've just got the cholinesterase inhibitor. What time frame would be a healthy option, because this is LBD, to once you've taken that Sinemet away, how long should you wait to add in the namenda to the story to see if that will help with these generalized symptoms that are happening in this particular patient?
So inherent in your question, Pat, is that there's supposed to be some period of time in between.
Exactly.
And I guess I am not familiar if there is some report or research out there that suggests there should be some time apart. I don't know of it. I'm more than willing and happy to be educated on that. Okay. But from my standpoint, I will wean somebody off of drug A and then turn around the next day, the day after, and, and start the process of, weaning them on to drug B. Is there some rationale for separating them in time?
Yes, absolutely. There is. And the mantra is one change at a time. And the second mantra is low and slow. So that means, and I'm basing this on your predecessor's teaching. That went on with me for me over and over and over, because I wanted everything done fast. And many caregivers do, because we're so stressed by all these symptoms. And he was like, you have to slow with LBD, you have to slow everything down. And so when that, let's say, for instance, Sinemet's withdrawn, you wait at least, he would make me wait like 4 or 5 days, maybe even a week, every now and then 2 weeks. And I'm like, oh, but he was saying, I think it was about the processing. And you just needed to almost, I had the impression, giving the brain a chance to kind of recalibrate before you introduce a new chemical. But that I know that low and slow and one change at a time are the huge drug mantras.
Always.
And so I think it was maybe an abundance of caution, or maybe experience of all those decades of treating this particular disease. And it was just stretch it out more than you normally would, and definitely more than maybe with another kind of dementia because of the hypersensitivity.
Yeah, I definitely agree with, all of those principles. The one change at a time thing drives my patients crazy. And, I always tell them I'm very sorry, but the only result of making 2 or more changes at a time typically is that we have to backtrack all the way to the beginning instead of just having to backtrack by one drug. And so you ultimately end up losing more time than you gain if you start, make more than one change at a time. Okay.
Does that fit in? Because I know that your philosophy and your predecessor's philosophy were very similar. And that was a big question that I had, is that piece of it also there for the LBD patient?
And so if you're asking me, do I or will I wait some period of days between? Yeah, I mean, I think that that is a very reasonable precaution to take. Not one that I have to this moment, done very often. I one drug at a time, start low, go slow, had not considered putting time in between changes, but now that you're telling me that, I think that it would be reasonable to let somebody, and definitely, if somebody's, I think, having a side effect, I do have them wait, stop this drug, we're going to wean you off of it, and now we're going to wait a week or two because I want to see if whatever that was got better. As we know, especially with Lewy body patients, right? Everybody's fluctuating all the time. You can have a good day or even two just because it's Tuesday. And that doesn't mean that the side effect actually was caused by that drug. You have to wait long enough to figure out whether it's really gone. But I will now put that into my schema for patients going forward. Oh, I see Patrick.
Okay, Patrick, you have a
waving.
question.
Yeah, is there, when do you just like stop the medicine? I mean, when do you say, all right, there's enough's enough, or do we know if this, because with this medicine, I mean, it seems that the carbidopa levodopa helps Suzanne, but we don't know if the memantine is helping, and she's on the patch, and everybody I talk to says, that's all we have is the medicine, stay with the medicine, but when is it time to say, enough with the medicine, or is there a time to say that?
So I have two answers for you, and they're different. So the first answer is the general principle. Okay, the general principle is that these medicines don't stop working at late stages of disease. It's just that the person's at a late stage of the disease and the medicines don't actually halt progression, right? And so even though they're at very late stages, it doesn't mean that the drug isn't doing something. And that something may or may not be relevant to the person's condition. So sometimes the medicine is preventing them from being incontinent. That's huge, right? Even though they may not be able to talk anymore, they may not be able to remember, your face from one day to the next. But if you don't have to toilet them, that's a big deal. So in general, I recommend that we keep those drugs on board, right? However, and especially with Lewy body disease, what works at one point, at one stage, stops working as well because side effects kind of overwhelm the upside or the positive benefits of that drug. And Lewy body patients, especially later in the disease, have this massive circadian cycle disruption. As you were pointing out, your wife is sleeping upwards of 12 hours a day. And we know that namenda has a mild but definite sedating quality to it. So in your particular situation at this particular time, there may be utility in weaning her from the namenda to see if she won't wake up more, be more interactive with you off the medicine. And I don't know how to advise you since I don't know all of the details, and this really isn't meant to be kind of a medical consult to replace a medical consultation. But I will say that it is conceivable that at this point, perhaps, at least for a time, that should be considered. It's a conversation with her neurologist or geriatrician, whoever is managing.
And is there like a drug to help her get up and out of bed? like like to give her more energy?
I am hoping to start a pilot trial within the next 12 months or so with a drug called modafinil or armodafinil to see if that might actually benefit the population of DLBers who have this excessive sleeping. It's a drug that was approved by the FDA for use with people with hypersomnia from sleep apnea that's not adequately resolved with apnea treatment. So there is attention being focused on this problem, and there is the possibility that some medication intervention will actually help more than it hurts. Right now, today, I don't have a drug to tell you about or to recommend. And for God's sakes, do not give her Ritalin or Adderall. They're more likely to cause hallucinations than do any good. And the best advice is to find fun things for her to do that will kind of motivate her as much as she's motivatable to get out of bed, and then to stay engaged, even if you have to hire someone to assist you in keeping her more engaged and stimulated during the day. Because no one who sleeps all day long is going to sleep all night long very well, right?
And like an amphetamine is not in the
No,
market.
that's Adderall. Yeah.
Okay.
Do not under any circumstances allow anyone to talk you into putting her on an amphetamine. She will start climbing the walls and hallucinating left and right.
Okay, thank you.
Okay, we have another question here from Natalie Bergen. Hi, Natalie Bergen. Haven't seen you in a long time. What about B12? My dad's B12 was low, and so shots helped with some energy.
Well, forgive me, Natalie, for being flippant. I can't resist. Your answer is in your question. So your dad's B12 was low, and that's the key. If you are deficient in any micronutrient, then your body will have problems. That's almost kind of the definition of what it means to be deficient, is we know that below a certain amount, the body can't do its sort of metabolic internal housekeeping properly. So replacing it, repleting it, getting it back into the normal range is helpful. That doesn't mean that anybody with a normal range B12 is going to do better if you make them super therapeutic, which is the medical term for, going above and beyond the normal range. So hyper normal anything doesn't help. And it's why now most doctors and doctor groups don't recommend taking a multivitamin every day unless you have a deficiency or unless you have a problem where your diet isn't right. You don't need a multivitamin either.
Rachel, you had a question.
I do. I'm fairly new to this, although my husband's symptoms are almost exactly those described by Patrick for his wife. But you were referring to the stages of, I don't know whether it's stages of dementia or stages of Lewy body syndrome or Lewy body disease. Can you elucidate a little bit for me, because I'm so new at having to deal with this?
The stages that I was referring to they're considered stages of dementia, though they were developed from observations of Alzheimer's disease patients primarily. And I belong to a consortium of Lewy body researchers, one of whose tasks is to revise the staging scheme to better reflect what goes on in Lewy body disease, a little bit more accurately. So understand that it is a staging scheme created in one population being applied to a different one. But it's called FAST. Oh God, and I'm not sure does somebody know offhand what the acronym stands for?
Lynette, usually good with that stuff. Can you remember?
If I FAST staging here, I'm Googling it real quick.
Functional assessment of something.
Right? Okay. And so there are formally 7 stages in this FAST staging scheme, where stage 1 is actually just normal. So I think that's kind of not so great. In my opinion, there's 6 stages. But number 1 is normal. Number 2 is subjective cognitive decline. Number 3 is mild cognitive impairment. Okay, so the first 3 stages are not dementia on the dementia staging scheme. Dementia starts with stage 4. So that's why I tell people, don't freak out if your doctor's told you that he's already stage 5, because stage 4 is mild dementia, 5 is moderate dementia, 6 is severe dementia, and stage 7 is pervasive or late stage dementia. Is that answering your question?
It's answering it technically. I guess that I'm going to have to hang around more to find out more about what I'm
If you Google the functional assessment staging scale and you look at what it has descriptions next to, like, what are people doing when they're at stage 4 or stage 6, and you, the caregiver, are the one who is in the best position to figure out what stage your family member is in by looking at those descriptors and seeing which ones fit best.
May I plug something in here real quick that may help Rachel and some others, and Dr. Bozoki also? This may be a little tidbit to share with your colleague. Which colleague is doing that? Which one on the Scientific Advisory Council is doing the staging? Do you remember?
So it's this clinical care committee that I am. They assigned me to, that is putting together or working to develop a revision. So it's not one person.
Some good information that I did not create. The people who created, and Rachel, if this is your husband you're taking care of, I don't know. There's a site called LBD Caring Spouses. LBD Caring Spouses, which is an online support group. I'm one of the moderators for that group. Long ago, the original founders of that group put their heads together as caregivers and created an LBD staging. It was all just by their experience. This may be helpful to that committee, because these are caregivers who were in the trenches every day, and they really did sort through it. And it is a much more complicated than what we were told to do initially, which was for LBD, you've got early, moderate, and what is that last stage?
Severe. So early, moderate, severe, and late is the one.
But this one is specific to LBD. And if you're a member of the LBD Caring Spouses group, you can join online. In the files, you can go and find that very long list of staging symptoms that show up at home. And so
I think that I didn't know that. I think that's what we're using as our sort of our preliminary. We're editing that to come up with a cleaner, shorter, I believe, because it's definitely not the fast list that we're using.
Second part of my question, and as I say, Patrick's descriptions were very familiar to me. My husband can sleep 23 hours at a stretch. And he is beginning to push. He gets angry with me for suggesting that he eat any additional foods beyond what he has in front of me. Is this an unusual part of Lewy body disease? The sleeping and the food?
It's it's not unusual. I would venture to guess that he is at a fairly late stage of his disease. I don't know if that's true. And people who are ill, you know, they have a bladder infection or something with earlier stage Lewy body disease will also behave this way. But it is often the case that the very late stages of all the dementias involve excessive sleep and a lack of interest in eating and drinking. And I'm afraid to tell you that that is often a weight loss. If I see that combined with a weight loss of 10+ pounds and or repeated infections, that is an indicator to me that this is a person who's ready for palliative care and possibly a hospice referral. I may have just overstepped my bounds, but 23 hours is a lot. Somebody asked, and that's the last thing I will do because we're past time, but somebody asked, what's a normal amount of sleep for somebody with dementia? And it's so variable, honestly. It's not like with children where, you know, your 6-year-old should get 10 hours of sleep or something. It's whatever seems to suit that person's physiology. Lots of people with Lewy body disease sleep up to 12 hours a day, and I consider that to be normal. If they're sleeping more than 12 hours, I look for ways to stimulate and find things to engage, provide some motivation, right, to be up and around a little bit more in the daytime. But right, but at a certain point, late stage Lewy body patients, they're fluctuating. They start to stay in that low part of their cycle more and more, and have the good days where they're awake and engaged less and less. And yeah, the late stages involve very little of being awake and engaged, and very much that sort of constantly asleep part of their cycle. That's as much as I can, I think, intelligently say without getting into the weeds.
Thank you so much.
Yeah.
This has just been fantastic, Dr. Bozoki. Lynette did add in another scale that's user-friendly in the chat. If you all want to look at that real quick and maybe even take a picture with your camera. It's the DBAT by Tam Cummings, useful scale for staging dementia, more user-friendly than fast, and you can download it at tamcummings.com. But we have gotten multiple comments here about how fantastic this has been. I'm over the moon on this one. This has really been so helpful. Dr. Bozoki, you are amazing. You've given us this big block of time. Would you be willing at some point to come back in the future?
Mm-hmm.
I'm putting you on the spot here.
Of course I am. Absolutely. And I'm actually looking actively to find a support group in this area that is for caregivers of frontotemporal dementia patients, because they too get short shrift from normal dementia support.